Good afternoon. I'm Dr. R. Duke Majan, CEO, founder of the Duke Spine Institute, and pioneer and inventor of the Duke Laser Disc Repair, the Duke Plasma Rhizotomy, and the Duke Piriformis Muscle Release. Our patient travels from Vero Beach. He was originally in Boston teaching at Harvard, and he's now retired, living in Florida and Vero Beach. He found us on the internet, like many of you, watched videos, and did an MRI review. He was on the verge of having a fusion of his back done by a spinal surgeon in Vero Beach, I believe, at the Cleveland Clinic. The surgeon almost convinced him to have an invasive surgery when he doesn't need it. And when he came to me in clinic, he was using a walker. He can barely walk. He has pinched nerves so severely, worse on the left side than the right. His nerve roots are severely pinched by the herniations to the point that he can't even lift his foot up anymore. So we're going to fix the pinched nerves and the herniated disc causing his back pain and his leg symptoms. Now, if you look at the MRI, X-ray and the MRI, you'll see that L5-S1 is also collapsed and degenerated, but it is not pinching the nerve roots. Therefore, we're not fixing it. We're only recommending 3, 4, 4, 5, where there are large herniations going backwards, where Jordan is showing you, pinching his nerves going in his legs. We're not going to recommend 5-1 unless it causes symptoms. Right now, 90% of his symptoms are coming from 3, 4, 4, 5. That's why we're fixing those two. Okay, we're going to get started. Are you ready, Dr. Berndes? Yes. I'm going to put some numbing medicine first, where I'm going to make the incisions on both sides. Good, he's not moving, which means he's pretty sleepy, which we like. If you have questions during this surgery, feel free to type them up. Henry will ask me the questions. In the meantime, we'd love to share with you, the audience, the 30 different causes of back pain that people have. And there are 30. And if you watch our video, you'll learn those 30. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke Laser Disc Repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke Plasma Rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. You can see from our video that there are 30 different things causing back pain. And this patient has, who is that? Is that you? This patient has 2 discs and the piriformis. But more important than his back pain is his leg weakness, profound weakness of the leg. Sean? AP. We're almost done. How long have you had back pain?
How many? 2 months.
No, when did your back pain start? For the very first time?
January 22nd of this year.
Uh-huh. All right. Sean? Huh? Did you get that?
You're having pain on your left leg? Yes. Right now? No. When it started?
That's when it started. All right. Are you comfortable? All right. Your biggest problem is the weakness in your legs, correct? And yeah, I know. Remember, I examined you yesterday. You couldn't even lift your foot up. It was so weak. All right, my friend. Are you having any pain right now? How bad is that on a scale of 1 to 10? What was the highest it went just then? How high? All right. Is that where you get your pain? Yes. Is that where you get your pain? Where you felt it? Is that where you get your pain? All right. We're going to put you to sleep. When you wake up, the surgery will be finished. Just count out loud for me. Nice and loud. I want you to count in Russian. Out loud in Russian. Russian. 1, 2. Just count in Russian though. Or whatever language you want to count. We just need to hear you count. Can you hear him? All right. Keep counting. That tells us when you go to sleep. So when you stop counting, we know you're asleep. Keep counting. Well, you chose English? English is too boring. All right. All right. So basically, the story on this gentleman is he has profound weakness, numbness in his legs. His big issue is not back pain, it's pinched nerves. He has large herniated discs. Show us on that x-ray, Jordan, one of those herniated discs. Look at this herniation at L3-4. It looks like, what is that mountain in Japan?
Fuji?
Mount Fuji. It looks like Mount Fuji on its side. It's humongous. And it's pinching the nerve coming out of the hole right behind it. That's why he has leg weakness. Big disc herniations compressing the nerve roots. His surgeon down in Cleveland Clinic wanted to do invasive surgery. But thank God he was on the schedule to have it done. But he saw us. He did an MRI review. He's a perfect candidate for laser surgery. And he decided to come here, less invasive, more successful treatment. So now he's here. Is he asleep? All right, he stopped counting, so I know he's asleep. We're going to proceed. Put a little numbing medicine in the fascia, and we're going to advance the dilator down to the herniation. We're going to start with L4-5. He also has a piriformis syndrome. We're going to treat that later. That's in his left buttock. We're going to first start with the discs. Any questions?
Yes, these first two questions are coming from Faisal on Facebook.
Welcome, Faisal.
First question asking, hi doctor, hope you're well.
Thank you. I hope you're well as well.
And you're doing a great job as usual. At the lumbar spine, I have a cyst that's pinching a nerve and I get some sciatica pain. What should I do? Thank you.
Yeah. So first of all, you should do an MRI review with me because cysts rarely cause pinched nerves. The only cyst that can cause a pinched nerve is, well, there's two types. There's cancerous cysts, which I hope you don't have, and then there's synovial cysts. But there are also cysts that doctors will tell you are pinching your nerve when they're not. And you have to watch out for those doctors because many of them try to do surgery for the cyst when you don't need surgery. So if you have an arachnoid cyst or Tarlov cyst, do not have surgery for an arachnoid cyst or Tarlov cyst. It will not help you. Instead, if you have a synovial cyst, then you can do surgery for the synovial cyst. That's only if it's causing symptoms, okay? Where's the adapter? Oh, all right. Great question, Faisal. My advice is let me tell you what's wrong so you get the right answer and you're not guessing. Now, if I feel you have a cyst causing your problem, then you should get it fixed. All right. Keep the questions coming. We take questions throughout surgery.
Next question from Faisal once more.
Hold on a second.
Not
Guys,
a problem.
I have no irrigation. Why? That would be helpful. Sorry, go ahead.
Not a problem. Coming from Faisal once more on Facebook asking, doctor, if the spinal cord is in an electrical cable when people are unfortunately
this look so
paralyzed due to a massive trauma, why can't surgeons repair the cord back together, goo or anything, to restore the cable's function? As an electrician, I used to repair electric cables. Thank you.
Yeah, that's great, but we can't repair the spinal cord because what happens is, number one, when you cut the axons, which are like little cables, the nerves die, the nerve axons die, they shrivel up, and scar tissue forms. It's the scar tissue forming that's the real problem. So We've done some studies where we try to prevent the scar tissue from forming, and that seems to help. But we're a long way off from repairing spinal cord injuries.
At this moment, no current questions. So in the meantime, why don't we show the audience of how it is that a herniated disc causes back pain and how it is that we cure it.
I think it's great. Okay, go ahead.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see from our video that the disc tear and herniation cause severe inflammation in the back wall, which then causes back pain. This patient, it's not a back pain issue. He's got a leg weakness issue. And leg weakness comes from pinched nerves, which he definitely has. By the way, I'm grabbing and I can feel the needle from the other side because this is a bilateral case. Give me another scope.
Yes, sir. Please open another one, please. Thank you.
You can test things like this on a one level, but on a complicated case like this, not a good idea. Any other questions?
Yes, we just got a question coming from AAKK on YouTube
Welcome back, AAKK.
asking, excellent spine scan video, Dr. Duke.
Good.
What type of change do you hope to accomplish with neurosurgeons and orthopedic spine surgeons in order to start implementing the DLDR surgery to be practiced mainstream?
That's a great question. I think the biggest issue that prevents our procedure from becoming more mainstream is reimbursement. Right now, the insurance companies pay for this surgery, but only rarely and sporadically. And so out of 20 surgeries, we may get one that gets paid. The other 19 go unpaid. Surgeons cannot afford to do surgery that doesn't pay. So surgeons will not adopt a treatment that doesn't pay them. Okay, period. They've gone through a lot of training and education. They have businesses to run. Every doctor's office is a business. It has employees. They all want a lot of money to stay there. So you have to pay your employees very well. Typically, surgeons will have 15 to 20 employees per surgeon. So just do the math. That's a lot of money. Plus you have to pay rent for your building. You have to pay for some medical supplies, which are very expensive. So running a medical practice is running a business. And it's not a cheap business to run. It's some of the most expensive business to run. So to get doctors to adopt this procedure and recommend it, they have to get paid. And if we're only getting paid 1 in 20, you can't run a medical business like that. You go out of business. So they would go out of business. They would have to go and flip hamburgers or do something else. So the first thing that has to happen for wide-scale adoption is reimbursement. The insurance companies know this, so do the implant companies, and they don't want this surgery widespread because every patient that has this surgery does not get a fusion, does not get a stimulator, does not get a laminectomy, does not get an artificial disc, does not get a cage, does not get screws, does not get any of those devices and biologics, cadaver bone, PRP, stem cells, that these companies are making billions and billions of dollars profit every year. They know if this surgery becomes widespread, they will go out of business. That is 100% for sure. Okay? So they don't want to go out of business. They have the publicly traded companies, they have a responsibility to the shareholder. They don't have a responsibility to the patient. But the doctor has a responsibility to the patient. It's the doctor's job to do what's best for their patient. So there's a conflict of interest when the surgeons are taking money from a company that has an obligation to the shareholders to make profit by putting metal devices in people, and they're hiring doctors to do their work for them, surgeons, and the surgeons are getting paid nicely to recommend fusions and spinal cord stimulators and medical devices and implants. But then the doctor has an obligation to the patient to do what's best for the patient, and what they're recommending and getting paid for is not what's best for the patient. So it creates a conflict of interest, and that's why our government is against doctors getting kickbacks from those companies. So they've made those kickbacks illegal, but these companies have found a way to legalize kickbacks in the form of what you see in the movie, which are consulting fees and development fees and royalty streams for products that are developed by the company, and then they give ownership to the surgeon for co-development. So they have these ways of getting the surgeons money that only to the surgeons that are using their products, okay, and recommending their products routinely and training other surgeons to use their products. So it's a very corrupt system that's highly conflicted. It will never fix itself. It's only getting worse. And in the end, patients are getting recommended treatments that are highly invasive, dangerous, and don't work. So that's what the movie is supposed to expose. How do you fix it? It all starts with getting consistent, good reimbursements for doing this type of surgery. We need to get paid as surgeons. In the end, the surgeons are the ones making the recommendation for surgery to the patient. It's the doctor's patient. It's not the insurance company's patient. It's not the hospital's patient. It's not the implant company's patient. It's the surgeon's patient. So the patient and the doctor, they have a relationship, and the doctor is supposed to recommend the best treatment for the patient, not the best treatment for the doctor or the implant company. That's the problem. So how do we fix this? Well, if surgeons were paid to do this surgery, they would probably do this surgery and recommend it more. But right now, with the reimbursements being very inconsistent from the insurance companies, we can't get doctors to do this. Does that make sense? So that's the problem. And that's the solution.
And at this moment, no current questions.
All right, good. We're going to be done shortly. I apologize for the blurry image. We're going to get that fixed in just a moment. But so far, everything's going well. This is all the herniation right here, all herniation. You see the laser is zapping this bluish colored stuff. It's
Yes, we do.
extremely scarred up, a lot of scar tissue. It's calcified. You see the gold color there? That's all calcium, okay? And if we need to buy another scope, please. How many do we have that are functional?
We have around 8 right now.
How many?
8 right now.
Buy 2 more.
I sent 2 for this. So
Yeah, but we,
10 in total. Alright?
yeah, send this out.
Yeah, no problem. It just takes
But
2
also
weeks.
see if,
I'm doing like,
what is the cost of buying a new one?
I can find it for probably $3,000. No, I need.
Really? How many can you get?
Not a new one. Just
How many can you get?
well, I can talk to the different people. It's just they sell it. I found it.
You found them?
Yeah, I find it.
Oh, tell me how many you can get. I want to buy like 5 of them.
Okay.
At that price?
Okay.
That's a good price.
Yeah, yeah. It is. Because
Grabber?
the new one is like a 12,000.
I know, but if we can get those and maintain them, you know.
So I was thinking about so we'll have a program obviously to fix and send a loaner or whatever right away, but I want to see what's the cost. Because they, you know what I'm saying, like I don't need to wait 2 weeks. I send one, they send me one the next day.
You're talking about Wolf or not Wolf? Wolf is quick.
Yeah, oh yeah.
Oh.
Yeah, yeah.
But the other company you wait 2 weeks.
Yes. Yeah, yeah.
It's
because
not
they're-
it's not bad.
It's not bad. But that's what I'm saying, like I'm sending little by little, but I can
Man, I'm grabbing
the other needle.
the other needle.
We good?
So we are inside the I need a laser. We're inside the other disc, the L3-4, I think. No, L4-5.
Yeah, 4-5.
Sorry, L4-5. And I'm reaching in with the grabber to try to pull out pieces of herniation here. And I'm grabbing the other needle from the other side because this is a bilateral case, meaning we're going from both sides. So you can't see the other needle yet, but I can feel it inside there when I put my grabber in. And we'll see it soon enough. All right, any other questions, Henry?
Yes, we have a question coming from AAKK once more on YouTube,
Yep.
saying, thank you for your explanation, Dr. Duke. Have you met any physicians who want to learn your DLDR procedure and implement it at their practice?
Yeah, I have met physicians that want to do the DLDR, but the problem is cost, and the problem, really the biggest problem, is reimbursement. Inconsistent reimbursement, not getting paid to do the surgery. That's a real problem, okay? Doctors have to get paid. They will not recommend treatment that they're not paid for. That is unfortunately a fact of life, and honestly, I can't blame them for that. And it's not because they're greedy that they need to get paid for their service. It's because they have an office staff to pay for. I've told people before, many times, I have no problem telling you, our tiny little company costs close to $1 million a month to run. All right, counting everybody's salaries and rent and electric and water. It's expensive running a medical practice. Now we run a surgery center and a medical practice, so we have both. But how are you going to pay for those bills if you don't get paid for your surgeries? That's the problem. So reimbursement is the most important step to getting this procedure widespread. Without consistent reimbursement, nobody's going to do it. Nobody but me.
And at this moment, no current questions.
All right, let's play another video.
Copy that. Why don't we show the audience how it is on...
Why don't we show the audience our preview
Oh my goodness,
for
yes.
the movie, since
Yes.
there's been some discussion.
Yeah, let's show that. Let's show the Spine Scam trailer.
Allegations have surfaced pointing to a major bribery scheme between medical providers and spinal surgeons. What we uncovered is potentially criminal.
This consulting package is worth $300,000 to $500,000 a year.
You know how this works. You lie to people in pain to make a buck. And I give you tropical vacations and pleasure cruises to make it worth your while.
Your fusion technique is looking very good. You stay focused and disciplined, you'll go a long way in this business.
Business? And I'd like to thank my friends Bruce and Red at Globazon for helping to develop these exceptional products.
I wonder how much that fucker makes from those implant companies.
You think he's on the take?
You know he is.
We need every one of our residents to be loyal to the program and loyal to the Globazon brand.
There's a new aspiring neuro at SD University Hospital. I want you to move in and land him.
And how far do you want me to go?
Whatever it takes.
You have lumbar degenerative disc disease. Spinal fusion is the only option.
Lately, I've noticed the hospital seems to be doing way too many surgeries. Like we're doing it just for the money, not because it's 100% the right call for the patient.
Your little prodigy's become obsessed with some sort of alternative laser treatment.
It's better for the patients.
For your own fucking good, drop it.
I feel like they're all pushing me to do what's best for them, not necessarily what's best for me.
Why can't anyone just do the right thing?
We do not need some morally virtuous renegade poking around. This could become a complete shit show.
What about our pledge to the industry? What about the welfare of our patients? What about our own moral code?
And if he doesn't listen, then cut him loose.
Hey, remember when that douchebag Dr. Bob used to be an idealist? Now he's just a capitalist.
Capitalists like money.
Yes, they do.
Welcome back. We are almost finished with our first of 4 discs that we're repairing. How is our patient doing, doctor? Let me have the grabber. Once again, there is a needle down here. We haven't quite seen it yet, but it's here somewhere. Huh? Yeah, it looks better, right? I don't know why.
That's what I'm saying. I manipulate a little bit.
No, but it's not consistent. So we've gotten rid of the herniation that was here. And let me just take a look. There is the back of the disc right there. We've gotten rid of most of the herniation. I'm going back in again. Let me have the grabber. I'm going to try to grab out a few more pieces of herniation. For those of you who are new to herniations, herniations are not one event. It's not one big piece of disc material that's stuck out. It is multiple fragments over time that get stuck inside the annular wall, and they cause typically inflammation. There's the needle. You guys see it? That's the needle from the other side. Pretty cool. We're going to come in the other side, but that's it right there. Okay? Now the laser fiber, for those of you wondering, is 1 millimeter wide. That's the diameter of this fiber. I don't want to get that piece of metal because it will melt that needle. But I want to clean up the herniation around it. So I'm going to work around it for just a minute. And, oh, did you move it? No? All right, I guess I did. A little bit of an optical distortion. But this laser will easily melt that needle, easily. We don't want to do that. Any other questions?
No current questions, but we do have a comment coming from AAKK once more on YouTube saying, "Thank you, Dr. Duke. That makes sense. Without reimbursement from insurance, it gets difficult to get this practice on a large scale."
Yeah, impossible. It becomes impossible. Doctors cannot do free care. I mean, it's already bad enough. The insurance companies have cut our payments for surgeries down so much over the last 20 years. I've watched my payments for traditional types of surgery like laminectomy, fusion. They've been cut by at least 50%, and by the insurance companies. And my brother is a neurosurgeon. He said the same thing. He's practicing in Tampa. He doesn't do laser. He does fusions and laminectomies and brain surgery. And he said that, even they're struggling to stay in business. They're actually considering selling to the hospital, his practice, which, in the past never happened. Doctors would maintain their autonomy and freedom. And that's important that doctors remain autonomous and free, because when you work for a hospital, you have to do what the hospital tells you to do. and if the hospital tells you to do more fusions, then you're going to recommend more fusions because you're making more money for the hospital. But they have CEOs at the hospital that push the surgeons and doctors to do more profitable treatments. That happens all the time, everywhere. That's why you read about it in the news. It's not legal, it's illegal, but they have ways of incentivizing the doctors to do more revenue generating procedures. So the system is broken. Doctors need to get back to doing what's best for the patient and still at the same time make enough money to stay in business and keep their office open and caring for patients. There was a time many years ago when my dad was a doctor that he would treat not just patients with insurance, but he would treat people who were indigent. They had no money, they had no insurance. He'd do it for free. And you know why he did it for free? Because he made enough money from the other patients that paid. He made enough money that he could do free care. You see, that's how medicine used to be. It wasn't just my father doing that, it was lots of doctors did it. And that's why doctors were the most noble profession, because they would donate their time, effort, and energy to treating patients for free in between the patients that paid. Well, now the payments are so bad from insurance companies that doctors don't have the ability to do the free care anymore. And they're looking for ways to make money. And a lot of those ways, unfortunately, are not good ways, like the movie shows you. They're basically getting kickbacks from the companies making all the money in order to recommend those treatments. All right, we're just about done with the first disc, and I'm going to move on to number 2. Any other questions?
At this moment, no current questions.
All right. I just want to clean up a little bit more. By the way, as I remove this bit of herniation here, it's like more of it falls from the roof down. So remember, the herniation is at 12 o'clock position. We're at the base of it, and I'm going to try to grab, if there's any more I can get, I'm going to try to grab it and take it out. Now the nerve root that is being pinched really badly is at the 12 o'clock position. It's just beyond the herniation, beyond this wall. And I can tell you the herniation here is pushing on it, pinching on it. So my job is to remove as much of this base of the herniation as I can in order to get the pressure off the nerve root. How's he doing? All right. Yeah, he's moving a bit. I think he's a little light. You're doing good. Lay still. It may be just a reflex. His body reflexively moving away from pain, because this is a painful procedure. That's why patients have to be asleep for it. If it wasn't painful, we wouldn't put them under anesthesia. All right, just about done. I want to make sure I get the left side particularly good, because this is the worst side. This is where he had the worst weakness. I'm going to make sure I get as much of this herniation as I can. Remember, no doctor can get 100% of the herniation. It's not possible. But we do as much as we can get to, and usually that's enough. Here's a piece. It just came out. Try one more grab. Any other questions?
At this moment, no current questions.
I'm grabbing the needle again. You guys hear that?
Yes, we do.
That's snapping. All right. I'm just looking at the roof here. You see a little vein all scarred up from chronic inflammation?
Yes, we do.
It's kind of like I'm trying to pull the legs of the herniation and pull it down, if that makes sense. And as I pull down, I get a little more out until I've gotten enough out. Let's show the audience one more time how the Duke laser disc repair works.
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK, 349-6922.
Welcome back. I know we have some questions, but I want to point out this patient in particular does not have much back pain from his disc. What he has is pinched nerves, and pinched nerves cause leg weakness, numbness, tingling, and that's exactly what he has. He came in a walker. He could barely walk. He basically had a horrific weakness in his foot, and that I would expect to get better over time and basically hopefully go back to normal. We'll see. Sean, is that it? All right. So we did the L4-5 on the left. We still have the right side to do. We're going to first do the left L3-4. That's next. Num. Sean? Now he's a fit guy, very fit. So he doesn't have a lot of excess soft tissue. All right, we're approaching the herniation. You can see it.
Yes, we can.
Shot. And I'll take those questions.
First question coming from Travis on YouTube.
Yes, Travis.
Asking, I recently had a ACDF yesterday. It's saying, how mobility am I looking at? What is the mobility I am looking at after the post ACDF?
Well, you fused some of your joints, so you're going to lose some movement. The truth is, it depends on who does your surgery. If it's done masterfully, then you will have no noticeable loss of movement. You'll have normal range of motion. But if it's not done well, you will have a stiff neck and a painful neck. And so I just don't know. It's too early to say. There's lots of bad spine surgeons out there, and they don't do good surgery. They do very poor technique. You know, believe it or not, spine surgery is not something, it's not like, manufacturing a car where the cars that come out of a factory, they're all identical, right? With spine surgery, there's tremendous variation. And every surgeon does things a little bit different than the last surgeon. So there are 6,000 spine surgeons in America. There are 6,000 ways to do the ACDF. And the way I do it is based out of performing over 1,000 ACDFs. I've mastered the technique. So where my patients come in, get it done, they go home an hour later. Grab her. And they do very well. They have no loss of movement. They have a normal life. And my complication rate is 1%. That means 1 in 100 of my patients will have a complication. Now, the average complication for ACDF is 50%. Okay? So, think about that. Mine is 1%. The average for neurosurgeons, spine surgeons is 50%. That's what's published. That's what we all come to expect to tell our patients. I don't tell my patients 50%. I tell them 1% because I know my own complication rate. But that means if 50% complications out there, that means there's a lot of bad surgery being done. Now, I was lucky. I was trained. Wow, look at this. Oh my, we got the big one. He is going to really appreciate that. There is a, so we always talk about herniations and how they're really made up of lots of small pieces. But sometimes we get lucky. Can you turn the light on that, please?
We can see it.
Look at the size of that thing. That's 1 centimeter wide and almost 3 centimeters long. That's a big one. I'm not going to say that's the only piece in there. I'm going to go back and look. I don't assume anything. As a scientist, you can't, a good scientist, you can't assume. You have to prove. So I'm going to go back and see if there's any more. Here's another piece. Not as big, much smaller, but still a piece. So my goal is to get as many of these pieces out as possible. Anyway, getting back to the ACDF question. You changed the scope?
Yes.
I don't know how much movement you're going to have. It all depends on how good of a job your surgeon did. And if I had to bet, I would say your surgeon did not do a good job, just based on probabilities. I don't mean to upset you, but I'm not here to make you feel good. I'm here to tell you the truth. And unfortunately, sometimes the truth is not what people want to hear. The good news is whatever he didn't do right, or she didn't do right, I can fix, usually. So if you're not happy with your fusion results, you got to schedule an MRI review with me and I'll figure out what's wrong. Okay? But what you should expect, what should happen is you should have normal movement. Of your neck without pain. Normal movement without pain. That would be what I would expect if they did the surgery properly. Okay? I'm sorry if that's not what you want to hear. I feel horrible for you. I feel horrible for people that get multiple spine surgeries and still have problems. There's a lot of people out there like that. And the reason why we do this broadcast is to raise awareness about a lot of things. One of the things we want to raise awareness about is that there's a lot of bad spine surgery out there. Okay? It's the truth. Why is it important to raise awareness about that? Why do I feel like I have the needle? Do I have the needle?
No.
Hold on, ready?
Oh, yeah.
I have the needle.
Yes.
I'm pulling the needle from the other side. How funny. All right, so it's hidden in that piece of herniation, but I was actually grabbing the needle from the other side. And it's somewhere in there. You can't really see it, but it's hidden just below that. There it is. You see that?
Yes.
You guys see the needle?
Yes, we do.
Right there.
Yep.
Right there.
Yep.
So I'm trying to get the pieces of herniation out, but I'm grabbing the needle, and I don't want to grab the needle. So I have to work around it. There we go. So anyway, the reason we do the broadcast is, honestly, when I say come to Duke Spine, what I'm really saying to you guys is stay away from a bad surgeon who will screw your life up. All right? But I'm trying to say it in a nice way that's professional, without sounding too arrogant, and without scaring you too much. Look at all that pink material. That's inflammatory tissue. Now this patient knows everything about inflammation because he is a biochemist. And he taught biochemistry at Harvard. He's a very intelligent man. We get along great. We spend a lot of time together in pre-op, talking about his career. I can't tell you any more about him because I don't want to give away his identity, but I'll just suffice it to say, inflammation is a biochemical process. And a biochemist would truly understand the implications of chronic inflammation and how it works, how destructive it can be. Luis, still having an issue here. You see? Huh? You see it? Just seems a little blurry to me. Doesn't it?
For me, it looks a little bit dark.
Huh?
A little bit dark, like dark side.
Not worried about dark. It's not dark. Its exposure is fine. It's the clarity of the image that concerns me.
When I work on that, sending little,
Huh?
sending the worst, and then, you're gonna have
Was this a recently repaired?
no.
I don't understand. We do a lot of the surgery where these are all just heavily used.
Sometimes sometimes we just keep it there and then we reuse the same one.
We can't do that. You have to cycle them.
Correct.
I mean, it's like common sense. All right, everything's going very well. We're just talking about the scope image. This is all herniation and scar tissue right here. Massive, massive, massive herniation. And it is really scarred up. Now this patient can appreciate that, inflammation is a biochemical process that is cellular and biochemical. It's cell-mediated biochemical process. Basically, the herniation gets stuck in the annular tear and triggers an inflammatory process in the posterior annular tear around the herniation. So what happens then is the body sends inflammatory cells here, and those inflammatory cells, they're called polymorphonucleocytes. They then release these enzymes that lyse or break up tissue. Okay, their purpose is to fight off infections like bacteria, protozoan. But there's no infection here, just a foreign invader, what the body perceives to be a foreign invader, which is actually the herniation. Okay, so the body perceives the herniation to be foreign, like a bacteria, therefore it attacks it like it would attack a bacteria. And that attack is mediated through the inflammatory process. And it turns out that the herniated disc or herniated nucleus is pro-inflammatory, meaning that it causes inflammation, heavy inflammation, okay? And all that inflammation is mediated through what are called cytokines or chemicals released locally in the area of the tear where the herniation is stuck in the tear. And those cytokines are released and they cause lots of changes, cellular changes. For example, they cause the capillaries in the area to become more leaky and allow cells to transgress, to cross over from the endothelial side into the tissue side or interstitial side. These cells then are the polymorphonucleocytes. Hold this, please, where it is. Okay, it's moving and it's really delaying my surgery. You got to help me by holding it. Okay. So the polymorphonucleocytes see these chemical mediators, high concentration in the area of inflammation, because they're leaking across. Fucking hell, dude. They're leaking across the capillaries into the endothelial side, attracting polymorphonucleocytes to marginate, attach to the endothelial side, and they attach and then they cross over through these junctions between cells. They get into the interstitial tissue around the posterior annular tear and the herniation, and they start releasing their enzymes from their little I don't know what you did with the bag today, but this is not working. I'm getting soaked. I don't know why it's so hard to get this right. So basically, these cytokines or chemical messengers attract the polymorphonucleosides or neutrophils to attach to the endothelial wall and cross over into the tissue right where the inflammation is. Those guys then release their lysosomal contents, which are proteases, lipases, and sucrases, basically breaking up protein, carbohydrates, and fats and trying to destroy the bacterial wall. But there is no bacteria. So instead, they destroy the tissues in this area, your own body's tissues, and cause destruction. It's like a battle happening with a imaginary enemy. But the enemy is not bacteria or fungus or protozoan. The enemy they're attacking is the herniation, the nucleus pulposus. And over many years, with the buildup of this inflammatory tissues, which is mostly scar tissue, you get this mass effect on the nerve root nearby, behind the tear, and that causes pressure on the nerve root, and as the scar tissue continues to build up in the inflammatory area of inflammation, it presses on the nerve root more and more and causes more and more nerve damage over time. And that's where we are with him. He's a tough guy, and he's put off getting this fixed for a long time, and now we see what's been going on here. His body has been attacking this herniation for a long time, and only when he had really bad weakness did he finally present, you know. So this is what happens when you ignore a problem you have for a long time, and we encourage people not to ignore these problems but to get them fixed. All right, any other questions, Henry? I think there was still another question earlier.
Yes, we have a couple more questions. This next one is coming from AAKK once more on YouTube. Asking, in your opinion, Dr. Duke, is the central herniation at L3-4 likely causing the dorsiflexion at L4 weakness, or is it more likely that the L4-5 posterior lateral herniation? Oh, is it more likely that it's the L4-5 posterior lateration herniation?
Yeah, so unfortunately, you guys don't have the benefit of seeing all the pictures that I do. I always look at all the images and paint a 3D picture in my mind of what's happening. This patient has severe compression of the nerve roots at both L3-4 and O4-5. You guys are only seeing one picture, this right here, one picture, one image, okay? And you cannot recreate a three-dimensional model in your head with one image. I can. So this patient has severe nerve compression at L3-4 and L4-5, both levels. And it's in the lateral recess and the foramen mostly. There is central herniations never cause symptoms. Never. Damn it. They can cause back pain, but they cannot cause leg symptoms. Central herniations don't cause symptoms. I need another scope.
Yes, sir. Bring me the last one to get to. Scope, yes.
I need one that we know is in good shape. You understand?
Yes, sir.
Thank you. I should send you my MRI. Igor and Frankenstein did a terrible job. Did a terrible job on me, and I'm 4 years post-op. I'll send my MRI. So after the cleanup service you perform, can it possibly fix the weeble wobbles and I to able to move my toes and feet up and down?
Yeah, first of all, I'm very, very sorry to hear that you had a really bad surgery and a bad outcome. It's all too common. It happens all the time, all around the world, bad surgeons. I've seen bad surgery even from German surgeons that are supposed to be the best in the world at doing disc replacements. Very bad results, very bad surgeries, okay? I won't mention names, but the point is bad spine surgery happens everywhere, except Duke Spine Institute. And there's a reason for that. We do the same exact surgery all the time, and we've perfected it. And thank God patients don't have complications from the surgery. It's very safe. So we avoid complications. We avoid adjacent segment disease because we're not fusing or putting any metal in. So we avoid a lot of the problems that other types of surgery have, like blood clots in the legs or weakness, nerve damage, spinal fluid leak. All that's avoided with these types of surgeries that we do. So really, what I can offer you is a free MRI review to figure out what's wrong and then give you a plan to fix it. All right? And the good news is you can do it from the comfort of your own home. You don't even have to come to Duke Spine. We do all this from YouTube. Not YouTube, I apologize. From, what do you call it? The Zoom link. So we'll send you a Zoom link at the time of your appointment, and we'll meet face to face, and I'll spend 10 minutes and I'll figure out what's wrong in 10 minutes. It seems crazy that I can do that, but I can do it. I can do it, and we'll have answers for you as soon as we're done. Okay, so submit your MRI for review. That's my advice. Just about finished. This was the left side, the worst side. I could see why. There was a lot going on here, and this has been going on for a long time. All right, hopefully he's going to be very happy with his results. Let's see. Grabber. Any other questions?
At this moment, no current questions.
All right, I'm going to wrap this side up in a minute, and then we're going to go to the other side. We're halfway done, but we did the hardest half first, okay? So there's the needle on the other side. There's actually a really big herniation right here. I can't grab it because the needle is stopping it from coming out. See that? It's wobbling around. Scheiße. People ask me when I went to Germany, did I learn how to speak German? The answer is yes, I did. But you're not going to be happy with what I learned. It's not really conversational. I don't know. I think I need to try to get that. Come on. Sometimes these tools are a bit awkward. Come on, Luis, I always put in the same spot. Oh, there it is. If I could just get it. Oh yeah, we got it. Wow, look at that. Holy moly. That's another gigantic herniation. So you guys see this?
Yes, we do.
Give me the measure. People say the herniation looks like crab meat. It does. It does look like crab meat, and it almost feels like crab meat. But only crab meat that's not very good. Let go. Like, that's the kind of crab meat that if you crack the crab and you wait too long, a few weeks, it gets super hard and rubbery. That's what that's like. Okay? But fresh crab, no. Hey, you want to take those? All right. Any questions?
At this moment, no current question.
Amazing stuff, folks. Amazing. This guy was going to have his back filleted open by another spine surgeon. Thank God he chose to do this surgery. Much better for him. Put pressure. All right. So we've shown the 30 causes of back pain. We've shown the movie trailer. We've shown the DLDR.
Correct.
Why don't we show the piriformis, because we're going to do that later.
Copy that.
A piriformis muscle tear can cause lower back pain and sciatica. A piriformis muscle injury causes a tear, in which piriformis muscle inflammation causes back pain. And also, piriformis muscle inflammation may cause sciatic pain. The best treatment for piriformis muscle syndrome is the Duke piriformis release. From there, the piriformis pain is permanently eliminated. The advantages with the Duke piriformis release is that it's an outpatient procedure, which would take up to about 30 minutes. Minimal bleeding and pain after the procedure with an immediate recovery and return to work the next day, as well as a 99% success rate with permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
Welcome back. You can see from our animation video that once you tear the piriformis muscle, it can become extremely painful. That's due to inflammation again. Remember, inflammation is the cause of back pain or pain in the body, period. We have discovered there's many diseases caused by inflammation out of control. Inflammation is a process that involves cells and chemical mediators that is ancient. It's old. It's been around a long time, like Israel and Palestine. And it's unfortunately not a very sophisticated system. And basically, it's not specific in recognizing enemies, hold on, like your immune system is. The immunological system is far more specific. The inflammatory system is not. The inflammatory system attacks, recklessly. And causes what's called collateral damage to your body in the area of inflammation. That's what we're dealing with here with these disc injuries, with the facet injuries, with the piriformis injury. It's all inflammation gone wrong. And the crazy thing is I'm literally leading my entire neurosurgical, orthopedic surgical industry in thought on this, understanding it, and I'm trying to teach other surgeons it so they understand it, but they ignore it. And they want to just keep doing these equally barbaric and non-specific treatments like laminectomy fusion, spinal cord stimulator, mild procedure, barricade, injections. I mean, the list goes on. There's hundreds of treatments people recommend for spine pain, back pain, neck pain, that are just as non-specific as inflammation. Now, the immune system is a far more advanced and intelligent system that targets specifically bad things. Our immunological system rarely ever causes collateral damage. Not never, but much less than the inflammatory system. The inflammatory system, it's like that movie you see. Hey, it's just as fuzzy. Hmm? Hold on. Hold on. Turn the light on your face. Put the light here. Hold on, folks. We're doing a little testing. That looks good, right? It's not the camera. What are you doing here, man? Something I need to know? Huh? Hold on, let me see if I can get the focus better. No. Bring another. Bring me another. Huh? Where's the other scope? No, where's the last one? Let me have that back because that's better than this. Apologize, we're changing our scopes around. Let me have it, please. All right.
We have a question.
Sure.
Coming from Pawn Lust on YouTube.
Yes. Hi.
Saying, I missed your streams. Amazing to watch
Hold
live
on.
spine surgery.
Thank you. Let me have a more light. Thank you. Sorry, Pawn Lust. We're just trying to get our equipment working properly. Laser. But thanks. Yeah, we unfortunately didn't have any surgeries that we could stream, and I spent more time in my garden, which was good, but I also had some no, it wasn't your fault. It was the laser's fault for not turning itself on. So if we don't have surgeries, we have nothing to broadcast. So it is what it is. But thank you. I miss them too. All right, guys. You have a grabber? So we're working on the right side. We've switched sides. This is a bilateral procedure, left and right. And we are on the right side now, and I have to try to remove the herniations here. What is it, Louis? Any questions?
Yes, the question from Ponlus was asking how the guy with spondylolisthesis and the severely degenerated disc turn out. For him, fusion seems like an inevitability in the long run. I'm surprised he insisted on avoiding it at that stage.
Yeah, that guy turned out great. He has no pain. He has no more back pain, no more leg pain. He's very happy. Fusion is not an inevitability. The only reason you think that is because your thinking has been corrupted by, unfortunately, all the misinformation out there in the internet, and doctors and nurses, lawyers, whoever. They're all misinforming you and everybody else. Jordan, would you back Nikki up, please? My point is, it's not necessarily your fault that you're misinformed. It's the world's fault, but we have new information. And that new information is that spondylolisthesis, degenerative disc disease, degenerated spine, scoliosis, kyphosis, facet arthropathy, all those conditions no longer need invasive surgery. We can fix them with minimally invasive Duke procedures.
Ponlus commented, I meant that his issue was also structural with the disc not aligned. It wasn't just the herniation.
Oh no, it doesn't matter, Ponlus, that there's other structural findings. They don't cause symptoms. They don't cause symptoms. They're asymptomatic. You see, that's the whole point. The whole point is if you know where the symptoms come from, which we do, then you can target the source of the symptoms, which actually is not the whole spine. It's just a tiny, tiny, tiny little spot. That's what I discovered. That's why it's so significant. You see, doing a fusion for spondylolisthesis is like shooting an ant with a shotgun. Sure, you might get the ant, but you're blowing up everything else around it. It's totally unnecessary. The spine may look bad to you and everybody else on MRI and X-ray and CAT scan, but it's not the problem. Leave it alone. People have the thing about it truly is that lots of people have scoliosis and no symptoms. Lots of people have kyphosis, no symptoms. Millions of people have spondylolisthesis, grade 1, grade 2, and 0 symptoms. So why is that? The answer is simple. Because those are not the cause of their pain or symptoms. So we got to stop thinking about them as being the cause. Most doctors will tell their patient, if they want to do surgery on that patient, they're going to say, oh, you have spondylolisthesis. Look at the bones, they're out of alignment. You need a fusion. And that's how they sell the fusion. Because you can't fix that with therapy. It's always going to be there. You see, the first thing a patient thinks when you tell them you need back surgery is, why don't I just do physical therapy? Can't that fix it? And when they see bones out of alignment, they realize physical therapy can't fix that. So that's a way for spine surgeons to sell fusions to you by showing you something that can't be fixed by therapy or medication. You guys are the suckers that believe that. But the reality is that that's not the cause of your symptoms. Therefore, you don't need that surgery they're recommending. All you need is to get to the source of the symptoms, make a diagnosis, which is what I do at Duke Spine and other doctors don't do, and then you know exactly what's wrong and we know how to fix it, because the fix is always going to be the same for whatever the problem is. You understand? I like to use the analogy of a fire in the kitchen. If you see smoke coming from your kitchen and you don't have a fire extinguisher, all you have is water and a towel, what are you going to use? Do you know the right answer? She said a towel. Smart. Towel is that's right. So you have to diagnose the source of the fire, because if it's wood, you can use water. But if it's grease, you cannot use water. You must use a towel or a fire extinguisher. The point is, you have to diagnose the source before you administer the treatment, because the treatment could be wrong for that source. And that's what I'm trying to tell you. All these surgeons doing fusions are just fusing because of scoliosis, kyphosis, listhesis, and the patients are going for it because they don't see an alternative that's going to work, because they see a slippage of bones and they're told that your spine's out of alignment, you need screws and rods and a fusion. So they believe it because it's believable. But the truth is, you don't need it. And that surgeon is lying to you if they tell you that's your only treatment. You see, the difference is I know the truth because I've been a fusion surgeon and I've been a laser surgeon, and I've done them both. And I've had patients with listhesis that absolutely refused fusion. And we did the laser surgery and it cured their pain. Look at this inflammation right here. You guys see the pink?
Yes, we do. Yes, we do.
Yeah. Thank you. I heard you the first time. But the point is, what matters most is not the slippage. Slippage is inconsequential. It's just something there for you to look at, but it is not the cause of the symptoms, ever. Ever, ever, ever. That's what I've learned. And by the way, I used to be one of those surgeons that told people, you need a fusion because your bones are slipping. Why did I do that? I did it because I truly believed it. That was before I had done laser surgery. I actually believed they really did need a fusion. Now, do your surgeons telling you that today believe that? Probably. But shame on them, because our laser surgery has been out for 20 years now, come this June. 20-year anniversary. So they can say to you, I recommend a fusion for spondylolisthesis because that's the only thing that works. They can say that to you out of ignorance, or they can say it to you out of dishonesty. They're either lying or they're ignorant of the truth. And I don't know which one it is. But what kind of surgeon do you want? You want a lying surgeon or you want an ignorant surgeon? Neither, right? Most people don't want a lying surgeon and they don't want an ignorant surgeon. They want somebody who will tell them the truth and who knows what the hell they're doing. That's Duke Spine Institute. But we're the only ones. We're the only ones doing this surgery, and we're the only ones who will be honest with you about it. And that really comes down to my leadership, because I don't believe you should lie to people, and I don't believe you should hurt people to make money. I think that's wrong. So it's because of my own personal beliefs that we have our philosophy at Duke Spine of doing what we do the way we do it. And we don't lie to people and tell them you have a slippage, you need a fusion, unless they really don't have another choice, which is very rare. We can fix 98% of slippages, grade 1, grade 2 symptoms with just doing our laser treatment and our plasma treatment. The slippage will never be fixed, but it'll always be there, but it won't cause any symptoms. And we've done that, by the way, on probably 300, 400 patients now. And we've been successful 100% of getting rid of their back pain and their leg symptoms. 100%. So you tell me who needs a fusion for slippage when we can fix it 100% and better than fusion surgery with our Duke laser disc repair. Huh? We burning through the jewels? How many? 46,000? Yes? For all the discs or just this one? Yeah, this one is taking a lot of energy. What we're talking about, folks, is the laser machine is telling us we are using a tremendous amount of energy here on this one disc, and I can tell you why. Look at all the scar tissue. All that white stuff and gold stuff is old, thick, dense scar tissue, and dense, old, thick scar tissue takes a lot of energy to break up the covalent bonds holding all these collagen molecules in the scar tissue together. That's what a laser does, by the way. It transmits energy, electromagnetic radiation, from the tip of that glass probe that you're seeing right there. It transmits it directly to whatever is at the end, which I direct it to this herniated material and scar tissue in the back of the disc. So that laser energy is basically going straight into this material and being absorbed, and the amount of energy is so tremendous that the tissues can't hold it. They just blow up, they break apart. It's quite gratifying. Any other questions?
Yes, next question coming from Pawnless once more on YouTube, asking, I suppose that makes sense. I'm also curious if you still found ways of further refining the surgery / healing over the past 5 years. Do you still find yourself learning a lot even after 20 years? I'd love to see you get more thoracic patients too.
Yeah, thank you, Pawnless.
There are so few doing them. It is very effective surgery for it. You won't have much competition.
So few, I love it. Pawnless is a funny guy. Funny guy or girl, I shouldn't assume. I don't know what Pawnless is. But listen, Pawnless, you do make me smile under my mask, okay? So first of all, I suppose that's right. Pawnless, understand something. I don't say what I say because I want it to be true. I say what I say based on observation. I am a scientist. True scientists like me, we don't make things up. We go based on observation. Okay? And what happens is a true scientist will make observations about the physical world around them. And they will make observations, and then when they see consistencies, they will write laws. Basically, laws of the universe, right? All right, like E equals mc squared, or all energy cannot be created or destroyed. It just changes its form. Laws of thermodynamics, laws of physics, they govern our universe, okay? But there are laws of biochemistry as well that govern our universe. Biochemistry is not so different than our physical world. It's part of our physical world, just on a microscopic molecular scale. The point I'm trying to make is, when I say that people with spondylolisthesis don't need the fusion, it's based on observing hundreds upon hundreds of patients undergo my treatments and be cured of their symptoms, 100% cured. So when you see that every single time, 100% of the time, without any deviation over hundreds of cases, then you start to realize the truth is that you don't need to do a fusion for spondylolisthesis. Okay? It's not that I want to say that, it's that I've observed it. And because I've observed it, it's fact. And it's not one observation, it's hundreds upon hundreds. Basically 100%. So I appreciate your skepticism, and all I'm saying is I was skeptical too in the beginning when I started doing these surgeries for spondylolisthesis. But when I saw that the patients got 100% symptom relief every single time, I realized it wasn't coincidence. It was that we are actually addressing the true source of their symptom, which is the inflammation happening in the annular tear. That's what I'm treating right now. How many joules are we at? Wow, we're going to 60 joules on this disc. Okay, now we've done probably 60 before. I think my record is 65, but we're getting awfully close to breaking a record on this disc. Just for reference, the normal herniated disc will take about 30 joules, right? Yes. And we're already at... Yeah, so we're at doing 45 watts, and this patient's already taken 60 kilojoules. Yeah, on this one disc, which is remarkable. He's going to break a record. Oh yeah, we already did the other side too. Yeah, so you're right. So you have to combine them. So how much? 100 kilojoules. That's incredible. That's a lot. It's not going to hurt him in any way, but look at all that scar tissue, right? That's a wall of dense scar tissue. Basically, in the biological world, this is concrete. I mean, this is not as hard as bone, but for soft tissues, this is the thickest, hardest you can possibly get right here. All collagen and some elastin. Scar tissue. All right. The other thing Ponla said was what, Henry?
I'd love to see you get more thoracic patients too. There are so few doing them.
That's right.
It's a very
so few doing that. There's nobody doing that. Okay? You may have watched some surgeon doing a costotransversectomy or a transpedicular approach, right? But there's nobody doing endoscopic thoracic surgery but me. And the ones that do it are removing all the bones out of your spine. They're drilling holes, or they're going through the thoracic cavity. It's extremely rare to see it, but there's nobody doing what I'm doing. unless they've started doing it after they learned how to do it from me. So I'm not aware of anyone else doing thoracic transforaminal endoscopic surgery in America. Maybe Korea, there's somebody starting to do it, but not in America.
We have another question.
Yeah.
Coming from Kimba on YouTube.
Do you say Kippa?
Kimba.
Oh, okay.
K-A-M-B-A. Kimba asking, can
Grabber.
a microdiscectomy
Actually.
cause adjacent segment disease?
Can a microdiscectomy cause adjacent segment disease?
Correct.
Absolutely, yes, they can. It can. It can. And the reason a microdiscectomy can cause adjacent segment disease, almost done here, is because the surgeon that does a microdiscectomy must remove part of the facet joint, that's F-A-C-E-T joint, and a facet joint is a joint between two vertebrae, and they can actually cause changing of your biomechanics of your spine by removing the disc material and disrupting the facet joint. I would not do a microdiscectomy. It is an old procedure that does not work. And if it works, it's temporary and you'll be back for a fusion. All right. Just about finished. This is the last bit of concrete. See that, Berndes? Then we got one more disc and we're done. This has been a lot harder than I thought it would be, but I'm very pleased with our progress. Any other questions?
Yes, this comes from Ponlus once more on YouTube, asking if he's available. Maybe that spondy patient can give a testimonial. I am shocked that it can work with that much degeneration and structural misalignment. It does break the paradigm. And oh, I didn't know regular microdiscectomies affected facets.
Yeah. Yes, they do. Microdiscectomies drill away facet. Yeah, we don't, by the way, when we do our testimonials, we don't call people up and bother them at home and say, hey, will you do a testimonial? All right? These people have already paid a lot of money for their surgery, and they don't want to be bothered by doing a testimonial at home. They do those testimonials in our office because they're already here, and I asked them to do it. All right? So it's really not an inconvenience for our patients that are already here in the office, and we just bring them into the room and we do a testimonial. But when they're home, how are we going to do that? Are we going to fly them back for a testimonial? I mean, I don't know about you, but that costs a lot of money. How am I going to fly them here, pay for their hotel? That's not how we work. We don't do that. We just do testimonials because they're here and they agree to it. But we're not going to go calling people a year later saying, hey, can we fly you back to Duke Spine to meet with me and do a testimonial? That's not how it works. If we were able to cure their back pain with our medicine here that we're putting in, then why don't all the other surgeons that do spine surgery have patient testimonials the next day after their surgery where the patients are saying, I have no more pain? Because if we're doing something not so special here, they should be able to do it too, right? So why don't they have those videos? The answer is because they don't exist. Their patients are not pain-free. Their patients are never pain-free. Not the next day, not the next week, not the next month. Duke Spine Institute patients are pain-free, and the pain-freeness starts the next day. It doesn't start, the next day and then disappear. If it was a transient pain-freeness, then every spine surgeon could have a transient pain-freeness. Where are their testimonials? We have hundreds and hundreds of them. That's because our patients are pain-free. So you don't need a testimonial from somebody that is spondylolisthesis. We've done over 300. Damn. Well, that's interesting. So what happened is is I've melted this this needle, and I can't get my guide wire through, which really sucks. I have to redo it. Yeah. I have to redo it. So that is number 3-4. So we're just going to take this out, and you can see the tip is melted and I cannot get the guide wire out. You guys see that?
Yes, we do.
Put pressure, please. So unfortunately, I have to, you're a little too close. I have to start over again. Just an inch away. All right, open up the window. Yes, good. We're almost done, but I need to finish this last disc here. Shot? All right, not too bad. We're able to get there pretty quick. Shot? So yeah, testimonials, we don't want to call our patients and harass them to do a testimonial at home. And for the people who are naysayers and don't think that our patients are getting true long-term pain relief, then if we're making all this up, then why don't other doctors make it up and have testimonials just like us, right? So I hate to point out people's stupidity. It's not, I take no joy in it, but it's something that they themselves should think about rather than insult me with comments that are clearly meant to discredit my statements. All right, numbing. Right, Berndes? If our hundreds and hundreds and hundreds of testimonials are fake, then how come other doctors can't do the same thing? Right? Can you imagine if our patients didn't get the pain relief they expected? We would be lawsuit out of business. Yet we have no lawsuits. I mean, it's just common sense. I don't know why people can't figure that out. You have to spoon feed that to them. But it is what it is.
We have a question.
Yeah.
Coming from Lance on YouTube.
Uh-huh.
Asking, what's the difference on an MRI report if it says mass effect on the central aspect of the cord versus effacement of the ventral cord?
Sorry, I'm just focusing right now. That looks good. Go ahead and take it out. Yeah, so great question, Lance. Effacement means the herniation is just touching the cord. Mass effect means it's pushing against the cord, changing the shape of the spinal cord. The spinal cord should be biconvex and in the neck. And when you see the herniation actually flattening the cord or changing the convexity to make it concave, that's mass effect. Effacement means it's just touching it. The difference is between, if you look here, my finger is effacing the skin on the patient's back, but there's no mass effect. Now I'm pushing in deep and there's mass effect. Does that make sense? All right, last disc. We're just about done.
We have another question.
Sure.
Coming from Ping on Facebook.
All right, Ping.
Saying, hi, Doc. How many untreated cervical disc herniations lead to paralysis?
Very few. Very few. So the question was, Dr. Duke, if somebody has an untreated cervical disc herniation, how many will lead to paralysis? The Japanese did a study many years ago where they just grabbed 1,000 people off the streets and they said, do you have any neck problems? The people said, nope, no neck problems at all. All right, we want to get an MRI. of your spine. So they did the MRI on 1,000 people with no symptoms at all. These are normal people. And they were all over the age of 45. And guess what they found? 900 out of 1,000, 90% had herniated discs in their neck. Herniated discs. What does that tell you? It tells you that most herniated discs are asymptomatic. Okay? And that almost everybody over the age of 45 has a herniated disc. That's what it tells you. But we don't treat them. So when you ask what number of herniated discs left untreated in the neck cause paralysis, the number is massively low. Somewhere probably, if I had to guess, 1 in 10,000. Not common. Maybe even 1 in 50,000 if I'm guessing. So it's rare. Now, if you have a herniated disc and you get rear-ended in a car accident, maybe then the herniation will get worse. And it'll push on your spinal cord and you become paralyzed. But it's uncommon. Don't let anybody scare you into surgery because you have a herniated disc that's asymptomatic, not causing any cord compression or cord damage. Okay? Now, if you have myelopathy, that's a different story. It's not asymptomatic. It's symptomatic. Myelopathy means that you have signs or symptoms of spinal cord dysfunction from that herniation. I need 5 minutes, Dr. B. 5 minutes. Oh, we have the piriformis. Yeah. So we're going to end the broadcast and we'll do the left piriformis. We'll bring you guys back as a separate stream.
We have another question.
Sure.
Coming from Pond Lust, once more on YouTube, asking, it seems to me that even small herniations as a result of heavy lifting are more symptomatic than those with no known cause. Does that match your experience?
That's a good question. I don't know the answer. I think that heavy lifting, if you okay, so first of all, a herniated disc always requires a tear in the wall of the disc called an annular tear before you get the herniation. So everybody with a herniated disc must first have an annular tear. The annular tear requires massive trauma to get an annular tear. We're talking, some kind of a slip and fall or a sports injury where you're hit hard, but some type of an injury to your spine. Now, I do have a lot of people who say, I never had an injury to my spine in my lifetime. And I say, you sure? And they say, yes. But there is one type of injury that happens that people have no recollection of. And that is during your birth, when you're born. If your OBGYN or nurse midwife, if they grabbed you hard and pulled you hard through your mother's birth canal, or even on a C-section, they can actually injure your spine when you're a baby. And baby spines are very easy to be injured. So you could have an injury from when you're a baby coming out of the birth canal. Okay? I've seen it. When I was a medical student at USC, I watched experienced OB-GYNs rip babies out of the uterus. And it was impressive how much force they used. And I thought to myself, how is it they're not hurting these little babies? And now that I'm a spine surgeon, and a very good one, I see lots and lots of people who are young, in their teens, like 12 years old, 13, 14, and they have degenerated discs with no history of trauma. Degenerated discs in their lower back. That means they injured the disc at a very young age, aka when they were babies. So I think that there is a situation where when we're being born out of the birth canal, the OB-GYNs are basically damaging our spines. But it's not, you're a baby, you can't complain about back pain, right? You don't know how to speak for the first few years of your life. For some people, they never develop that at all, right, Luis? But the point is, if you're having back pain later in your life, It could be a result of an injury to the wall of your disc as a baby or child. And then you get that herniation into the tear while you're lifting something heavy, like you're talking about right now. People that lift heavy things, they have pain. Okay, they're not herniating their disc. Well, they're herniating their disc at that time, but that's not when the injury occurred. The actual original injury occurred a long time ago when they were younger. They had an annular tear. And now they're squeezing out this stuff right here. You guys see the blue stuff I'm zapping with a laser?
Yes, we do.
That is the herniation. So this can get pushed out when you're lifting things that are heavy. And that's when you start to feel the pain. Because when that thing comes out, that's when it starts to hurt. All right, just about done with this disc. 2 minutes, and then we're going to be done with this live stream. So get your last few questions in. We're going to be back for a quick piriformis release. The reason we stop the stream and go to a separate stream is we're trying to keep our surgery videos categorized properly, like disc versus facet versus SI versus piriformis. So we want to have a separate stream for the piriformis. So people that are interested in learning about piriformis can watch the piriformis surgery.
No current questions, but we do have a comment coming from Pawnless once more on YouTube saying, that's fascinating. Never heard of that risk with births. And I've had really expected annular tears at that age to scar over.
No. No, annular tears may not scar over. Because if at the time of trauma your tear occurs, but you also herniate at the same time, now you have a piece of herniation stuck in that tear. It may not be big enough to cause symptoms, there we go, when you're young, but as you herniate more and you get older, you start to feel the pain. That's why there's so many young people with back pain. And, you know, they're unfortunately marginalized as young adults. They're marginalized by society, you know. They're told by their pediatricians and doctors, oh, it's nothing. You couldn't possibly have anything wrong. You're just imagining it. You're just going through puberty, or you're going through, you know, your teenage years. Just suck it up, buttercup. But they're suffering, and it's undiagnosed or underdiagnosed. So we need to pay more attention to the young people with back pain and start really getting MRIs and seeing what's going on. All right, we're done, and we'll be back with our piriformis in just a minute. Thanks.